Hi, everyone. Welcome to the HIV/AIDS Bureau's Have You Heard webinar for January 26th. We're glad to have you. Just a few items for housekeeping purposes. The call is being recorded and will be shared following the webinar. You will notice at the bottom of your screen that there is a CC for closed captioning box. If you are an attendee that requires closed captioning, please click on the box to bring up the captioning on your computer. And we will also have there's a question and answer pod during the webinar. There will not be any live Q&As, but if you should require a technical question, you can use that pod to send a question to our technical expert. Now I'd like to turn over the webinar to Dr. Laura Cheever, the Associate Administrator of the HIV/AIDS Bureau.
Thank you very much. And you were hearing just then from Amy Shackman, who helped organize these. So thank you, Amy. And good afternoon, and welcome to the Health Resources and Services Administration's first Have You Heard webinar for 2021. It's our monthly update from the HIV/AIDS Bureau. I'm Laura Cheever, the Associate Administrator for the HIV/AIDS Bureau, the HAB in Have You Heard, and I'm joined today by Heather Hauk, HAB's Deputy Associate Administrator, Antigone Dempsey, Director of HAB's Division of Policy and Data, Dr. Susan Robalato, Director of HAB's Division of State HIV/AIDS Programs, and April Stubb-Smith, Senior Advisor for HAB's Office of Program Support. We are so glad that you could join us today for this afternoon's webinar. Next slide. So we are excited to have you joining us for the first official Zoom webinar. We again have a very full agenda for you today, including an update on COVID-19 vaccines and the Ryan White HIV/AIDS program, an important update on FY 2020 CARE Act funding and no-cost extensions, a look at our most recent COVID-19 data report, highlighting data through November of 2020, as well as information on how to prepare for virtual comprehensive site visits. We'll also share HIV/AIDS Bureau updates, including recognizing HAB's Housing and Homelessness Month, which the Bureau observes each January. In addition, we're excited to have two Recipient Spotlight presentations today. Joining us is the Ryan White Part B recipient, Maine Department of Health and Human Services, who will share some insights on their virtual comprehensive site visit experience during the COVID-19 pandemic, and the Ryan White Program Part C recipient, Cincinnati Health Network in Caracol, who will highlight how they've addressed the challenges of homelessness, mental illness, and addiction in Cincinnati. Next slide. Before we begin with our COVID-19 update this afternoon, I'd like to share a few reflections. It certainly has been a tumultuous start to 2021 in DC, and we want to acknowledge that as federal employees, we swear an oath to the Constitution of the United States, and we recognize our significant roles as public servants. As federal employees, we will continue to focus on our mission to serve the public, especially in our work to provide both leadership and resources to ensure access to and retention in high-quality integrated care and treatment services for vulnerable people with HIV and their families. Last week, we experienced a transition to a new administration, and while at HRSA we are still awaiting the new priorities from this administration, we know that there's much work to be done, and we look forward in working together to end the HIV epidemic. Next slide. Turning to our COVID-19 updates today, we'll begin by sharing some information on COVID-19 vaccinations and the Ryan White Program recipients. Next slide. HAB understands that the COVID-19 public health emergency has been stressful for all of us. However, there is some really great news, and that is that the COVID-19 rollout has started and vaccinations are becoming available in our communities. Vaccination is the next critical phase and an important tool in stopping COVID-19. In December 2020, the FDA gave emergency use authorization for two different COVID-19 vaccines. Both vaccines have shown to be safe and are at least 94% effective in prevention of severe disease. When the COVID-19 vaccine becomes available in your communities, we strongly encourage you to get your COVID-19 vaccine. Last week, I received my first dose of COVID-19 vaccine as part of my role as a provider seeing patients in Johns Hopkins. Next slide. So all Ryan White recipients and subrecipients have a critical role in addressing COVID-19 vaccine hesitancy in distributing information about local access to vaccines. Many clients are reluctant to receive COVID-19 vaccination because they have questions about the vaccine development and safety and the appropriateness of receiving a vaccine given their HIV diagnosis. I can personally say that every single one of my patients who has become eligible for vaccine in their community has wanted to hear directly from me that I thought it was a good idea. We know that Ryan White HIV/AIDS program healthcare team members are a trusted source of information. And in HAB, we're going to encourage you to please develop plans for addressing clients' needs related to vaccine education and how to access the vaccine. Next slide. As you may have seen, HRSA HAB has released a new program letter and frequently asked questions related to COVID-19 vaccination on January 15th to provide additional clarification around the role of the Ryan White HIV/AIDS program recipients in supporting clients and providers through the COVID-19 vaccination process. The new FAQs address COVID-19 vaccine costs, vaccine hesitancy, and use of funds. In addition, the letter encourages Ryan White recipients to address both access to vaccine and vaccine hesitancy. You can access the new program letter on the HAB program notice and in the HAB policy notice and program letter webpage. In addition, access to FAQs can be found on the COVID-19 FAQ webpage on the HAB website. I'd now like to turn the meeting over to Heather House, HAB's Deputy Associate Administrator, who will provide some important updates on the FY 2020 CARES Act funding. Heather?
Great. Thank you, Dr. Cheever. Good afternoon, everyone. As we have shared during our previous HAB You Heard webinars, the HIV/AIDS Bureau encourages FY 2020 CARES Act funded Ryan White HIV/AIDS program recipients to continue to draw down your funding in a timely manner. The period of performance, as you know, for the FY 20 CARES Act is 12 months and ends on March 31st, 2021. So this year, in 2 months. Next slide. Over the past several months, we have actually received questions from several Ryan White HIV/AIDS program recipients about your ability to request a no-cost extension and clarification around carryover request. In response, HAB has developed 2 new FAQs to provide FY 2020 CARES Act funded recipients information and guidance on the process. On the topic of carryover, a Ryan White program recipient can request a no-cost extension of up to 12 months for your 2020 CARES Act award through HRSA's electronic handbook, or EHB's, prior approval module. In the EHB's prior approval module, the recipient should submit the following with their request: a statement about why the extension is needed, the duration of the extension not to exceed 12 months, project objectives the recipient plans to complete during the extension period, a detailed budget page, a budget justification for the unobligated funds the recipient anticipates will remain at the end of the current budget period. Next slide. On the question of carryover, if HRSA approves a Ryan White HIV/AIDS program recipient's request for a no-cost extension on their FY 2020 CARES Act award, the CARES Act recipients will not submit a carryover request, as these are one-year awards. If a no-cost extension is requested and approved, the FY 2020 CARES Act funds will remain available for use during that extension period. Next slide, please. Based on this update, you could be wondering how this impacts reporting on the COVID-19 data report, or the CADR, or CDR as we call it, if you do receive a no-cost extension. The answer is yes, you will be reporting. Recipients and subrecipients should continue reporting the CDR monthly as applicable. Recipient providers should complete a CDR every month for the duration of the FY 2020 CARES Act award period, including the period covered by a no-cost extension. Subrecipient providers and second-level providers should complete the CDR each month during their contract period. It's important to note that if subrecipients and second-level providers used all FY 2020 CARES Act funding in a single month, they would still complete a CDR each month until their contract ends. So please continue to follow the CDR reporting guidance provided through the data technical assistance providers. Next slide. So next we want to actually show an update on the COVID data report known as the CDR. In the fall, we did share a CDR update through August. Today, we'll look at the CDR updated over the last quarter. For that, I'll turn it over to Antigone Dempsey, the Director of HAB's Division of Policy and Data. Antigone?
Thanks, Heather. So thank you again. And I also just want to begin with thanking everyone again for submitting your monthly CDR COVID-19 data reports. We want to let you know that these data are incredibly important for us to be able to monitor our activities related to the CARES Act funding. And you'll see over the next few slides that providers have been using CARES funding to implement and expand services to prevent, prepare for, and respond to COVID-19. And we have the data to be able to show that. Also wanted to just note that we are aware of that many recipients have requested and received extensions on submitting CDR at different times, CDR reporting in order to establish contracts or set up reporting. So just note that there is missing data. This is preliminary data, and we do anticipate that these numbers that I'm going to show will change as more providers start to submit data covering these reporting periods. So next slide. So this is our telehealth capacity, for these slides, I'm going to be talking about the first reporting period and looking at that reporting period to our reporting period in November. We just received our data for December on January 15th. So that data is not included in these, but that's just sort of the layout of the data reports that we're sharing. So we started in the first reporting period with about 68% of our Ryan White providers reporting having any telehealth capacity. And then by November 2020, we see that that has gone up to 84%. And you see on here some of the most common telehealth services that have been reported by you all. Next slide. So testing, so we see on this slide that providers are expanding and implementing COVID-19 testing. The percentage of providers conducting COVID-19 testing increased from 29% as of March 31st to 48% in November 30th. So that results in about close to 9,000 Ryan White eligible clients and household members who've received COVID-19 testing in November. So next slide. So this slide is showing the folks that you're all serving who have been newly identified with COVID-19. So as you can see here, what we're showing is the number of people per month who are newly identified as having COVID-19. Those are the blue bars, and you can see starting from the January to March reporting period going all the way through to November. And then the red bar is adding all those numbers up to show that we have served a little over 15,000 eligible clients who have been identified with COVID-19. And again, these data are preliminary. That's a note on all of these slides. Next slide. So this next slide is looking at the types of services that have been provided over this past reporting periods. And you can see that the number of clients and also household members receiving services for each month on the slide. And so one of the things I want to point out is that there is most likely duplication here because the same people may be receiving services in multiple months. So just make sure to note that. So there will be some duplication across months. And again, you know, these are preliminary, but you can kind of see the curve that I think sort of goes along with the number of people testing positive as well, some sort of correlations there. So next slide. And again, I just want to highlight the services that are being received by our clients related to you know, the COVID CARES Act funding. And I don't think any of these are a surprise to all of you, but outpatient ambulatory health services, medical case management, food bank home delivered meals, AIDS drug assistance program treatments, and then also health education, risk reduction, and case management. So now I would like to turn it over to Dr. Susan Robolato, the Director for HAB's Division of State HIV/AIDS Programs. Dr. Robolato.
Thank you, Antigone. So site visits are an important part of the Ryan White program, recipient monitoring and oversight process. However, given the importance of the Ryan White program recipients in this local, state, and national COVID-19 response effort, as well as guidance from the CDC, HRSA HAB has postponed on-site visits since the beginning of the pandemic. However, as an alternative to in-person site visits during the public health emergency, HRSA HAB is continuing to move forward with plans for virtual site visits and will transition to in-person site visits if and when safe to do so. Next slide, please. We understand a virtual site visit is a different experience than on-site visits, and HAB has received several questions from recipients who have concerns about what to expect when it's your turn to participate in a virtual site visit. We wanted to take a few minutes today to provide some information about what is involved in the virtual site visit experience and how you can prepare to participate. As the division director for the Ryan White HIV/AIDS program, Part B, several of our recipients have already taken part in virtual site visits. On the slide, you'll notice that the breakdown of virtual site visits over the last 11 months and how many HAB is preparing for the FY 2021 year ahead. Since March of 2020, HAB has conducted 4 comprehensive virtual site visits, and 2 virtual site visits are currently in progress. In FY 2021, HAB has an anticipated schedule of more than 90 comprehensive virtual site visits. Next slide, please. When recipients are preparing for their virtual comprehensive site visit, it's important to note that while there are minor adjustments in the usual site visit agenda, all components of the comprehensive site visit are included in a virtual site visit. The virtual site visits are conducted using Microsoft Teams. The Ryan White HIV/AIDS program project officers will work with the Ryan White HIV program recipients and MSCG consultants to ensure there is IT support for the recipient, and MSCG provides support throughout the virtual site visit to address any technical glitches that may arise. MSCG will train the Ryan White HIV/AIDS program's recipient staff prior to the site visit so everyone is comfortable with the technology. The sessions range in time from 2 to 4 hours, and the sessions are spread out through the week. In a few minutes, one of today's Recipient Spotlight presentations will feature a Part B recipient who will share their firsthand experience with the virtual site visit process. I now will turn it back over to Heather Hawk. Heather?
Thank you, Susan. We'd now like to turn to some important HIV/AIDS Bureau updates. To begin, April Stubbs-Smith will share an important observance for our HAB that we do each January, Housing and Homelessness Month. April?
Thank you, Heather. Just getting my video together. Thank you, Heather. So I'm proud to serve as the senior sponsor to HAB's Homeless and Housing Work Group. Each January, the Bureau honors the significant work of many of our Ryan White program recipients who serve the unique needs of people experiencing homelessness. The HIV/AIDS Bureau serves a critical role in the intersection between HIV care and treatment and housing. There is a large and growing body of research that indicates that stable housing has a direct and powerful effect on HIV incidence, HIV health outcomes, and on health disparities. In fact, and this is powerful, housing is a more significant predictor of healthcare access and HIV outcomes than individual characteristics, behavioral health issues, and access to other services. And finally, housing is a proven and cost-effective intervention that can improve HIV healthcare outcomes. Next slide. Here is a look at our 2019 Ryan White HIV/AIDS program client-level data by housing status and viral suppression among Ryan White clients by housing status. Shortly, we will hear from our Ryan White HIV/AIDS program recipients in Cincinnati, who will highlight some of the incredible work they are doing to serve people with HIV who are experiencing homelessness in their community. For our next update, I would like to turn it back over to Antigone Dempsey. Antigone?
Great, thank you. Thank you, April. So we also wanted to let you all know that we just recently put out our AIDS education and training data report, and that is online. And we just want to thank all of our program recipients and the performance sites for their work on that. And it's available at the link here. You can also just go to the HRSA HAB website and find it there. Next slide. We also wanted to let you all know that we are, so in my division, we have our clinical and quality branch, and that's led by Marlene Matowski. And one of the things that that branch is doing is that we are developing a resource for clinical quality management staff across the Ryan White recipients and subrecipients through a listserv, so that we can try to help connect people to be able to share ideas and ask questions around clinical quality management work. And again, there's a link here for that as well. And you can see the email address if you have any questions about that. So I'll now turn it back over to Susan Robolato. Susan?
Thanks, Antigone. So as I highlighted earlier, several Ryan White program Part B recipients have already had the opportunity to experience a virtual comprehensive site visit. This afternoon, I'm excited to introduce our first Recipient Spotlight presentation. Tara Thomas from the Ryan White HIV AIDS Program Part B recipient at the Maine Department of Health and Human Services. Tara has been the data and quality specialist for Maine's Part B program for the last 12 years. She has more than 20 years of experience working in HIV services. Thank you for joining us today, Tara.
Thank you. Next slide. Oops. Hold on one sec. I minimized the wrong thing because, of course, technical issues. All right. So if you drive into Maine, you'll see a big blue sign that reads, "Welcome to Maine, the way life should be." So I included this slide in our overview to let the site visit team see a little bit of what they were missing in person. Next slide. Maine is geographically bigger than the 5 other New England states combined, but our population is only about 1.3 million. We have about 1,700 people living with diagnosed HIV in the state, and about 1,100 of them are enrolled in the Part B program. Our formula award for FY20 is $1.74 million, and our total budget, including Part B supplemental funds, rebates, and state general funds, is about $5 million. Our program sits within Maine CDC, our state health department. Next slide. Our first case of COVID-19 was diagnosed March 12th. In the first 10 months, we had over 31,000 cases and over 450 deaths. In the last 2 weeks, our case rate per 10,000 has actually increased to 281.7 from 232.7. And there have been another 6,500 cases and 108 deaths. Next slide. Our Part B program has a really small staff. My position is half funded by our formula grant and half through state general funds. I'm responsible for all of our policy and compliance work. And since I had participated in our previous 2 in-person site visits, I took charge of all the site visit preparation. During our 2016 site visit, we provided documents for and interviews with all of our staff. This time we were asked to only provide documents for staff funded directly by the XO7 grant, and they interviewed 2 out of 3 of us who are already participating in other parts of the site visit. We also have had a number of long-term vacancies in critical positions since our 2016 site visit. So I made a chart that I included in our program overview because I thought that that was really important context. Next slide. We've had relationships with our 3 contractors for more than a decade. They've all participated in past federal site visits and they're familiar with the structure. Only our subrecipient for direct services was required to participate in this site visit, so that made it a lot easier to schedule and manage. Next slide. Next slide. Our service portfolio is probably smaller than most states. Because of our 1115 Medicaid waiver, most people living with HIV are eligible for targeted case management through Medicaid. So funds that would have been spent on case management are directed to food, housing, and dental assistance instead. Most of our resources go into our HAB. Last fiscal year, HAB accounted for 86% of our direct costs. Next slide. Our 2011 site visit was before the current model for comprehensive site visits was put in place. So it was only our project officer and the branch chief who attended. 2016 was hard on us because we had a brand new program manager, we had a federal site visit, and we had to develop our first integrated plan. So we asked that our next site visit be a year early so that it wouldn't be on the same 5-year cycle as the integrated plan. Little did we know how 2020 was going to work out. About a month after our in-person site visit was postponed, our project officer asked us if we'd be willing to pilot a virtual site visit. Next slide. The first thing I did was contact our state IT to get their recommendations for the most secure platforms for video conferencing and document sharing. They recommended Microsoft Teams and OneDrive. Next slide. After that, I emailed all the different players involved. We had 2 people from audit and 3 fiscal staff. HR needed to provide documents, but didn't need to participate in the site visit itself. We partially fund 4 case managers. So between them, their supervisor, the fiscal person, the executive director, and their QM person, we had 8 people from our subrecipient who needed to be involved. That was actually the most logistically challenging. I asked them to coordinate the consumer meeting. They determined that their clients would be most comfortable with a conference call without a video option. During our previous in-person site visit, our subrecipient provided a conference room in their office, and the meeting was well attended by clients. This time, there are only a handful of clients who participated on the call. Next slide. About 5 weeks before the site visit, we had a practice session in Teams with our project officer and 2 consultants. 2 weeks before the site visit, we had a conference call with the full site review team and our staff to go over the agenda and document list. I was surprised to find out that the reviewers were already going through the documents in the OneDrive, so I made sure that they were aware that I was still compiling documents right up until the day before the site visit began. Next slide. I created a site visit folder in my personal OneDrive, and I granted full access to the site review team and our staff who were involved in the site visit. And then I created subfolders for client records and fiscal records. That let our subrecipient upload their client records directly without granting them access to everything else in the folder. And the same was true for the fiscal staff. We do centralized eligibility in our office, and we have a statewide careware network. So I provided the eligibility documents from our files and exported the case notes from careware for all of the case management clients that were selected for review. Our subrecipient was still mostly utilizing paper records, so they had to work out on their own how they were going to digitize assessments, care plans, and releases and get them uploaded. But they didn't report any issues getting it done. I started out by creating folders based on the categories on the document list. So it was admin, fiscal, HAB, and CQM. But things like RFPs and contracts were listed in multiple places on the document list. So I ended up just giving folders broad names based on the contents. Next slide. Teams didn't have an option for breakout rooms when we had our site visit, so I created individual meetings for each block on the agenda. It meant a lot of invites and links to manage, but it worked out well because it was easier to partition who needed to attend each meeting. I initially sent the invites directly from Teams, and that made it challenging because some of the site review team didn't have Teams already. If I'd sent the invites from Outlook, it wouldn't have been a problem. So just a logistic thing to know. Teams lets you create multiple meetings at the same time and then not attend the meetings you create, so it doesn't have the same host issues that other platforms like Zoom has. Next slide. Our program manager has administrative and fiscal duties. I have administrative and CQM duties, and we both have some HAB related duties. So that made it challenging to divide staff up for concurrent meetings, but that was a problem during our previous in-person site visit too. The final agenda and document lists were delayed for our last site visit as well as this one. It felt like more of a time crunch this time just because we were short-staffed and had extra work related to COVID. I didn't think computers did the blue screen of death anymore until mine did it coming back from lunch on the first day. That was the only major technology issue we had. Teams didn't have the large gallery view available at the time of our site visit, so we couldn't always see everyone unless they were speaking during the entrance and exit meetings, which had more attendees than the other meetings did. If we'd had to include our admin contractors and or staff that are funded by contracts and rebates, it would have been that many more Teams meetings to schedule and coordinate. And as I mentioned earlier, we had much less participation in this consumer meeting than the live one during our previous in-person site visit. Next slide. We were able to make last-minute changes to the agenda when people had extra time. We didn't have any major hiccups with Teams or our network access. I feel like I want to knock on wood about that. Everyone made it to their meetings without any issues. Because the site review team had access to our documents well in advance, there were fewer requests for documents during the site visit than there were during our last one in person. Having a virtual site visit allowed people who were working at home or different offices to participate without having to take time to travel. The acting branch chief and Dr. Robolato were both able to participate in both the entrance and exit meetings because of that. And during our last in-person site visit, I think the branch chief participated by phone for part of the exit conference, but that was it. Everyone was really flexible. Overall, I think it went really well, and I really wouldn't mind doing future site visits virtually.
Thank you, Tara, for that great presentation. As Dr. Cheever shared at the opening, I'm April Stubbs-Smith, the Senior Public Health Advisor in HAB's Office of Program Support, and I also have the pleasure of serving as the senior sponsor of HAB's Homelessness and Housing Work Group. I'm excited to introduce our next Recipient Spotlight presentation, Ms. Kate Bennett and Ms. Susan McIlvaine from Cincinnati Health Network, and Carolyn Yorio from Caracol. Kate Bennett has been the CEO of the Cincinnati Health Network since 2003, with oversight of all health service programs, including the Healthcare for the Homeless and the local Ryan White Part C program. She has dedicated more than 35 years advocating for equal housing rights and quality medical care for underserved populations. Susan McIlvaine is the Director of Behavioral Health for the Cincinnati Health Network, which provides primary and behavioral health care to people experiencing homelessness and individuals living with HIV/AIDS. In this role, she leads a multidisciplinary team that delivers specialized primary care and mental health services for people who are underserved and at risk. Susan has more than 15 years experience as a psychotherapist treating trauma-related disorders. And finally, Carolyn Yorio started at Caracol, Cincinnati's AIDS service organization, as a medical case manager in 2013. She moved to Caracol's housing department in 2019 as Associate Director of Housing. Caracol's housing department serves 250 households every year with a range of short-term services and permanent supportive housing options. Thank you for being here today, Kate, Carolyn, and Susan. Next slide.
Hi, everybody. My name is Kate Bennett. Thank you very much. And I want to just take a minute and introduce you, if I can, to the Cincinnati Health Network, so you could know a little bit about us before two employees, one from Caraco and one from the network, each give you their own take on homelessness and HIV and care for people who are experiencing homelessness. The Health Network was formed about 35 years ago. At the time, we were a partner group of 5 different community health centers in the Cincinnati area. We've evolved over the years with adding a healthcare for the homeless only program in 1988, and in 1990, a Ryan White Part C program. As an FQHC, we are patient-centered. We are funded exclusively to provide healthcare, comprehensive, integrated care for people who are experiencing homelessness. And just to put in perspective what we're talking about, even nationally, the latest statistics are that well over 500,000 people are experiencing homelessness on any given night throughout the year. 1/3 of those are unsheltered. They're living on streets, in parks, in subways, in woods, in camps, tents on sidewalks. A variety of different housing options exist in addition to that. So in the course of 1 year, 1.4 million people will experience homelessness. Homelessness itself is so transient. We don't always have in the care that we provide people the benefit of longevity. Some people are homeless for a few weeks, others for many years. And some people cycle in and out of homelessness. We know that all of the same medical conditions exist in the homeless population as are in the general public. But let's keep in mind, folks have no place to heal, let alone a place to be sick. The face of the HIV virus has changed dramatically in some areas of the country, and particularly in our area. The opioid epidemic has really impacted the homeless population significantly. It's increased the number of people who are homeless, and also the number of people at risk for contracting the virus. And so when someone is newly diagnosed with HIV and they're also experiencing homelessness, it can be a life-changing condition for them. It's really stressful to just have that diagnosis and then add on top of that they have no place to live, they have no space, and they have no resources for their basic survival. At the Cincinnati Health Network, as I said, we are patient-centered. We are striving to become a complete trauma-informed care facility. We do believe that it is our responsibility to show up, to meet the clients where they're at, and that the integration of care is really what makes a difference, that we have a seamless continuum of care and that people can enter in that care at any point, whether it's for food, a place to live. And we believe in a housing first model, and that we are there for the patients that we serve, and that it truly does take a village. So I would like to move this on to Susan McIlvaine, and she's going to talk to you about trauma-informed care and mental health and behavioral health services.
Thanks, Kate. Good afternoon, everyone. My name is Susan McIlvaine, and I want to talk with you a little bit about what the Cincinnati Health Network has been doing to sort of break down the barriers to receiving care. And I want to go back to something that April said earlier in her presentation, which was absolutely spot on to what we're talking about today. And that was when she mentioned that housing status is the most significant predictor of a person's ability to access healthcare, to have HIV outcomes be in a positive measure, be in a positive way, to access behavioral health and other services. With that in mind, that is how we as our network sort of sat down and thought about ways we were going to overcome barriers to services in our community and within the Cincinnati Health Network and our partner agencies. So we know that homelessness obviously is the #1 predictor in terms of getting people in the door and being able to serve them. We also know that addiction, the opioid crisis prior to COVID, was something that was rampant, particularly in the Cincinnati area. We're in a tri-state area that we have a great deal of traffic in terms of drug trafficking and opiate issues. Mental illness and trauma exposure, sort of looking at the amount of patients that we have in our clinic who have been exposed to trauma was staggering, particularly in our HIV clinic, and really kind of wanting to address how do we address that. And then just the overall limited access to care based on eligibility requirements that the hoops that people have to jump through to be connected to services. So these are all barriers that we kind of put in different buckets and really wanted to kind of talk about and put a plan in place on how we were going to help overcome these barriers to care. Next slide, please. So what we wanted to do is, first and foremost, we wanted to increase the population that we were reaching. So we wanted to create a registry that looked at the patients we'd seen in the past and make contact with them and ensure that they were not lost to follow-up through a registry that we have developed. We also reached out to our partner organizations to enhance and increase our collaborative efforts. And you're going to hear from one of our partners today, from Carolyn Yorio, my colleague. And also to create a multi-directional channel of communication. And that really is a multi-directional access channel as well. So using our services, whether it be in-house in our primary care clinic or our behavioral health services, or through our referrals, where we have warm handoffs for housing referrals, for addiction referrals, for legal counseling, if such the case, for reacclimation after incarceration, just a myriad of things that people might need. We have developed those communication or those collaborations with partner organizations and are able to make warm handoffs and assist in making sure that the loop is closed in terms of getting our patients referred. Next slide, please. So back to what I talked to you about earlier, the trauma-informed care approach really, when we sort of assessed our agency and really educated our staff and started to sort of implement that with our patients, really demanded that we open up a multi-point access into our clinic or into our network system. And what I mean by that is we no longer just start with a patient for primary care. Patients can come to us, they can be referred to us by Caracal, the housing arm. They can be referred to us by the HIV specialty clinic for behavioral health care needs, for primary care needs. They can come from just self-referred, just come to the clinic because they need to talk to someone. They need to talk about housing. They need to talk to someone to get advice on legal issues. So making our primary care, our FQHC, a home for contact with people that are safe, that will help you get the services you need. That's the message that we wanted to get out there. We also took a deep dive in terms of expanding our mental health care services. So we were offering counseling before, but what we've done now is we really have a detailed assessment process. We offer evidence-based psychotherapies that include trauma-focused treatments. We have approximately 900 behavioral health patients in our clinic, and approximately 30 to 40% of those patients that we know of, because not everyone will talk about it, but that we know of, that have endorsed a trauma either with their primary care or their behavioral health care provider. So trauma is a very big component in prohibiting people from engaging in services or asking for services, or even thinking they might need services. If you know what we know about trauma and post-traumatic stress, is avoidance is a powerful motivator for people to just avoid what the symptoms are, avoid the issues, in the hopes that they can keep them at bay or that they'll go away. So by expanding our mental health care offerings, by hiring behavioral health care providers that are trained and able to provide these services, has been really a wonderful thing. Also, we have our docs certified to offer medication-assisted treatment. So we provide that for patients who have addiction issues. And we have also, as I mentioned before, built a client registry of our patients, but we've also done a behavioral health registry that helps improve patient and provider treatment and outcomes, because we constantly manage that registry and are able to reach out to patients so no one is lost to follow-up. And while they're the next slide, I also wanted to share, before I turn this over to Carolyn, I just wanted to share an anecdotal story that's, sort of void of statistics, but I thought this might help kind of put into perspective what our approach has meant in the lives of our patients. So I'll just share with you a case study of a gentleman who's a 37-year-old male who has a history of significant incarceration in his life, an opiate addiction. He's receiving MAT. He has post-traumatic stress from a childhood sexual trauma. He's homeless. He has HIV, and he's not currently taking his medications when we met him. And he's also lost custody of his 2 boys. And his main goal at the outset of when we first met him was to get custody of his children back. That was his main goal. However, what was interfering with that is he was not able to do that because he didn't have stable housing. So we helped him sort of check off the boxes. We helped him get a stable housing. We helped him with legal aid to help get his children back. We helped him get a GED because he was incarcerated and wasn't able to finish his education. So he got a GED. We got him into HIV treatment. He's now compliant with his HIV medications, and his viral load is suppressed. And he's currently getting treatment for his post-traumatic stress disorder, and his self-report measures his scores are coming down, and he is getting better. So in addition to, just being an FQHC, we have helped this gentleman. Granted, he was very motivated. It was the right time, but through our collaborative agencies and through our work within our agency, we were able to help this gentleman get back on his feet and attain the one thing he wanted most, which was to be reunited with his kids. So we're really proud of what we're doing. And right now I'm going to turn it over to my colleague, Carolyn Yorio, to talk about how Caracal impacts people that are homeless. Thank you.
Thanks, Susie, and thanks for the opportunity to present today. So as we all know on this call, the stigma or the cost or other factors relating to being HIV positive can be contributing factors to homelessness. And homelessness can be a contributing factor to higher risk sexual and drug use behaviors that increase risk of HIV transmission or lack of medication adherence and engagement in care. So it's really factors that hurt one another. And so in order to address them, we address them together and providing housing supports in conjunction with HIV support. Next slide, please. So our model is to pair medical case managers and who are dedicated to HIV as their primary focus of intervention, and housing specialists whose job is to maintain stable housing. And we take these two these two teams of professionals and equip them with 3 interventions. One is the idea of housing first, that we provide housing without prerequisites to be a stable foundation. We provide harm reduction. So if there is drug use or sex work involved, we try to reduce the harm associated with those behaviors to keep people as healthy as possible in the life stage they're in. And then also motivational interviewing. So recognizing the client as their own expert in their care, helping them to identify interventions that will work for them and explore both the pros and the cons of those changes so that they can make plans they can stick to. Our teams are committed to coordinating with our partners, including Cincinnati Health Network and the other medical, mental health, and substance use providers in our area to provide services that support clients on all fronts and support the dignity and respect that's needed to maintain housing stability and address HIV and AIDS. And I want to point out as a final note, HIV and homelessness, we know disproportionately impact the LGBTQ community and the African American or Black community. studies have also more recently shown that COVID is also disproportionately impacting those exact same groups. And so this is a unique time where HIV and homelessness and COVID is a real threat to people living in our communities who are LGBT or Q and or are members of the African American or Black community. And so thank you for all the work that you are all doing. And I want to kind of end with a call to action to serving those groups well during this difficult time. Thanks.
Great. So first, I want to really thank you all for those great presentations, Tara, Kate, Carolyn, and Susan. We really do appreciate all the critical work you and your teams are doing both in Maine and Cincinnati to support the needs of patients, clients, and providers. I also want to just take a moment before we end to remind you of several key resources that are continuously being updated to support the work of the Ryan White HIV/AIDS program recipients. So next slide. We continue to update the HAB COVID-19 Frequently Asked Questions webpage as new information becomes available. For those responses, we encourage you to continue to visit the HIV/AIDS Bureau COVID-19 FAQ website noted there on that link. We also encourage you to visit several other web pages for critical information on the COVID-19 pandemic as it continues to evolve. I want to especially note CDC's COVID-19 vaccination website, which has a lot of great resources. Next slide. And that concludes today's Have You Heard webinar. The recording for today's event will be posted on HAB's COVID-19 webpage. Our next Have You Heard webinar will take place on February 24th from 2 to 3 p.m. Please mark your calendars and be on the lookout for the save your date. I want to remind you that as you continue to care for your families, your patients, and your communities, to please take time for your own self-care. And please consider getting a COVID-19 vaccine when it's available in your community. Last slide. Thank you again for the vital work you do in your communities during this challenging time, and thank you for participating on today's webinar. Have a great week.
That concludes today's webinar. You may disconnect.